There is a network which was extended. Oh, okay. He made part two, he made already part.
Is it live? Is it live? Yes, live. Okay.
They have one concept in Kerala. April is doing the course. Oh. And then it's going to UK.
Good afternoon, one and all. Those who are physically present here and those who have joined online. I request all of you to rise for the prayer.
धन्वन्तरी स भगवानमृतत्वदाता यो वैद्यकस्य गुरुराधिरणाधिकालात् योगार्थदेहमन आत्मसुखावहस्य नैरोग्यतस्य नितराञ्च नृणामितस्य तस्याहिणस्पदमहर्षिवरस्य शिष्या ये ते वयं प्रमुदिताननुभाग्यवन्तः तेन प्रतीपितचरं सुचिराशुभायुः वेदस्य दीपामिह तत्पुरतो धराम्यः येन प्रभां वयमिहस्य वितत्स्य दिक्षु ज्योत्स्नामृजार्तिशमनीं प्रभवेम दातुम् या दिव्यदार्थ हृदयाय हि मानवाय ज्ञेयं त्विदं भुवि कलापि च नाखिलैषः ज्ञेयं त्विदं भुवि कलापि च नाखिलैषः ज्ञेयं त्विदं भुवि कलापि च नाखिलैषः.
Please have your seats.
Oh, okay. He made part two, he made already part.
Is it live? Is it live? Yes, live. Okay.
They have one concept in Kerala. April is doing the course.
Now I request our head of the department, Dr. Kriji, to formally welcome our two speakers of the day, Dr. Krish and Dr. Sathish, by a small bouquet, which is a handcrafted bouquet from Ashram, Auroville Ashram, to make you remind of the Puducherry. And also, it's the customary to welcome our guest by shawl. Mahapatra can also assist. Mahapatra is our professor of plastic surgery. Okay, Dr. Sathish, please come. Yeah. Now I request our speakers as well as those faculty who are present physically, including Dr. Murugayan and Dr. Vijay Kumar also, with Dr. Mahapatra and Friji, to join the formal inauguration of the today's program by lighting the lamp. Dr. Friji, sir, Dr. Satish, sir, Dr. Sir Murugayan, sir, you can also light. Please have. Dr. Vijay, you can come. Padma, you can also join. Padma is our newly joined faculty. So I formally welcome all the participants offline and online. And this is our lecture series which we regularly conduct, which was initiated by Dr. Mahapatra and then is being carried forward as a part of our learning and knowledge sharing, not only for colleagues but also for the residents. And this program is being telecasted as a part of our telemedicine activities from JIPMER. JIPMER being the regional resource center for telemedicine designated by Ministry of Health and Family Welfare. And it is being telecasted to not only India, medical colleges, but also overseas, including all the SAARC countries, Bhutan, Nepal, Sri Lanka, Bangladesh, Malaysia, Thailand, and also Morocco, and those countries who have signed MOU with us. So this is the overview of the program that we will follow now. And the topic is very, very important, not only for the day-to-day practicing plastic surgeons, but also for residents, because invariably there will be a case of a leg defect or otherwise for reconstruction and skin malignancies. So keeping these 2 points in the mind, this topic is very, very important. And now we will begin with the first speaker, and I would like to introduce Dr. Krish Kumar, who is from Derryford Hospital, Plymouth, UK. And it is honor to be having with us because he's a JIPMERite and he was here long time back in 1966. And then Madurai Medical College and subsequently in other part of the country as well as in UK. As you can go through that he has traveled across the world and has not only presented papers but also published in peer review index journals. And his interest is in the reconstruction of skin malignancy, especially the facial skin cancers. So welcome you, sir, and thank you. And I request our first speaker to start. Before that, our second speaker also, we will complete the introduction now only instead of stopping in between. I think Dr. Sathish is known to everyone from SRM. And of course, he has done his higher education in England, including FRCS and DNB, and various membership is holding with various academic positions across the country and the world, with the vast experience working right in the UK as well as in India. And he's holding various responsibilities, right, as a faculty examiner and conducting various lectures and CMEs. So we are very happy that we have two eminent speakers. So thank you very much giving me this opportunity to introduce you as well as give this welcome address. Now I will request our Dr. Krish Kumar, the first speaker, to start his talk. Sir, over to you, sir.
Thank you. Yeah.
We will hear your research lecture.
Okay, thanks. Okay, start. Yeah. Thank you very much. I have a sense of déjà vu
coming here because 57 years ago I came here as a 17-year-old. So, well, you know my age. Um, it's very nostalgic to come and talk here, although I didn't expect this to happen. Anyway, let's crack on. So I'm going to talk about the. Can you hear me?
Yes,
Can you hear me? Yeah. Okay, so I'm going to talk about local plaques on face and scalp after excision of malignancies. That has been my subspecialty interest for many years before I finished in the NHS. What I'm going to talk about and I'm going to show you is just a series of slides that I did myself of my work during my time there. Interesting things, not routine, but interesting. And I covered all the areas of the face and scalp. And I'm going to place particular emphasis on the nose because nose, I'll talk about it later, but the nose has got more than 40% of malignancies on the head and neck occurs on the nose. I'm talking about skin cancers. Okay, so let's start. Right, I just put this up just to show you where I am from or where I was based. I'm not from there. This is a map of UK showing you England, Scotland, Wales, and Ireland. Disappointing. Okay, right. Okay, so Plymouth is down there. And you can see as a reference point London on the east of England, southeast England, and Plymouth is right down the southwest. Right, so the common skin cancers are that we used to see in, or we normally see in territory in the southwest, where the non-melanoma skin cancers, the majority of them were the non-melanoma ones, like the basal cell carcinomas, the squamous cell carcinomas, the keratoacanthomas, the Bones disease, which is the in situ SCCs, and various others. We also saw a whole lot of malignant melanomas, which is quite common down in, excuse me, in all the Western countries. Just go on to the etiology. We all know that skin cancers especially in the question of the white skin, is caused by actinic damage, sun damage. And all recent, in the last maybe 25 years, a lot of young people have been using sunbeds. They all want tans. We all want white again, but the white people want tans. They want the skin to be darker, so they use sunbed, and that is catastrophic for a lot of them. So in the old days, we would see skin cancers only in older people, but nowadays we see them in very young people. Coming on to the other causes, immunocompromised patients, we are transplant centers. We get lots of transplant patients, liver, and the rest. And then you get the genetic causes, which are the dysplastic nevus syndrome, and also the xeroderma pigmentosa. We don't see very many of chronic radiodermatitis causing cancers because they are much more advanced now, radiotherapy. Chronic ulcers, we used to see a lot of them in the old days, but not now.
Hello.
As modulus ulcer. Viruses, human papillomavirus is causing SCCs. That's quite common. When the sun shines, this is what people do there. We don't often get sun there in Northern Europe. So when they do get it, they all lie down in the sun in various degrees of undress, sorry. And that's one of the reasons why they all skin cancer. And they do that. If there is a continuous spate of sunny days, they would lie there doing that. Okay, so this is just a little slide to show you what causes skin cancers. Basically, as you know, the UV radiation or the actinic rays are classified into UVC, A, and B, or ABC. The UV radiation C is usually absorbed in the ozone layer, as you can see here. But the UVA and B go deeper. A is much deeper, they go right through the epidermis and the dermis, whereas B goes supposedly only up to the epidermis. There's a classification for skin cancers, which was done in America based on how quickly one sunburn. That's the types that's done. So 1, 2, 3, 4, 5, and 6 are the brown and black people. Brown and black don't burn easily because we have lots of natural sun protection. They say about 8 natural sun protection. Okay, just going on to all the examples. This is a group of people from the farming community who are exposed to sun all day long in the summer. So there's a lady up here with a BCC on her left cheek, another one, a large SCC on her right cheek, and an SCC on the lower lip, on the left, and this is one with a large keratotic lesion on the forehead. So these are the type of lesions. See, we see quite a lot of them in the outpatients. Just some examples of pigmented lesions, the displaced nevi that we talked about. On the top, we find these pigmented lesions, which when they turn irregular, that's when they are dangerous. They can be quite lethal, depending on how deep they are in the malignant melanoma. And on the right here, you see a picture of the xeroderma pigmentosa. I've only seen 2 people in my career. Maybe you see more here, I don't know. They don't usually live more than about 30 years because they get quite severe skin cancer. Usually lethal, and they usually die of metastatic disease. There's a lady that I talked about, immunocompromised, a patient who had a kidney transplant done about 60 years ago. So you can see the arteriovenous anastomosis on the left upper arm. He had plenty of small lesions. He come regulated to have them dealt with. Okay, so going on to the actual surgical techniques, we just have a little talk about that. Puducherry is the one who's credited with starting all these surgical excisions. He's the father of surgery, really. Not much credit is given to it. I think that's something that we all have to concentrate on. History of medicine. I'll go in deeply into that when we go to the nose. Next, the French started doing sliding or advancement flap. And then came the Italians who did the vertical flap, who distant sides. And then after the World Wars, there was a plethora of flaps which were developed and described, especially the vertical flaps, the axial flaps which were in the 50s and 60s. And in the 70s, there was a rapid development where we developed lots of flaps, including muscle free, perforator flaps, etc. So let's go on to some examples. This is an old lady with a BCC on her left cheek, which has been exercised with a 5.5 centimeter margin, and the defect covered with a local transportation plug. It's quite easy on the face of old people to do this because they are very elastic skin. This is a man who is 98 years old with a very thick melanoma on his right cheek, which has been excised with a centimeter clearance and repaired with a rhomboid flap. And you can see the flap being developed. That's a defect there, the rhomboid flap in place. And this is a few months later on the left side, and a few years later, since he was 98, he didn't want to be, when he reached 100, he didn't want to be followed up anymore, so he was discharged. Now, the case is a lentigo maligna. These are pigmentomas which could turn into, these are in situ melanomas, that they could turn into, so this is based as a excision biopsy, and it was reported as melanoma. Anyway, we had an adequate clearance of a 0.5 centimeter. On the face, you can't do more than a few centimeters. Again, repaired with a rhomboid flap. You can see that when raising rhomboid flaps of this size, one's got to be careful not to divide the nerves of the facial line. That's as long as they keep, as long as you don't go too deep in there, you will not divide them. If you're not sure, you can always use nerve stimulators on the nerves. So that's the flap in place and suture. This is an example of a reach-Y advancement flap, you can see there, which is drawn out. It's a lesion there, lesion in size, and a flap being developed. Now, when you do this, one has got to, this is based on subcutaneous pedicles. So you bevel the flap edges, make it as wide as possible, and you will get enough leverage, enough movement. You can see this is about 2 centimeters in length, and that is covered. Again, one's got to be very careful about the nerves deeper down. I don't go looking for it, I know I am, so that's where you keep fairly superficial. You don't go deep. If you dig in, you will injure the branches. So the flap in place, and you can see here it pulls the lower eyelid a bit. That usually such a, and that's a few months and a few years later. Again, this is an example of a very old lady with a keratotic lesion, again an ACC, well differentiated, big size, and repaired with a reach-Y advancement flap similarly, but very close to the lower eyelid. So she did have a bit of extrophy of the lower eyelid, but that settled after a few months. Now, this lady had a lesion which we could not be very sure of whether it is an SCC, nodular BCC or an SCC. So a wide excision and frozen section was done. And that came back as Merkel cell tumor. And they're very rare and quite lethal if you don't treat them adequately. So I can see this could be, if it was an SCC or a BCC, this could have been resurfaced with full thickness graft. Well, that's a good bet there. But I decided, because being a Merkel cell, you needed radiotherapy, so you needed a durable cover, which wouldn't bother the graft. So that's what we did. A nice large rotation cheek flap raised in place. And once the flap settled, we had radiotherapy. Another example, this was a BCC on the inner campus, just below the inner campus. And these tumors are usually very deep here. They go right down bone. And that's the reason why we had to gouge it out and see a big hole there. So that required two flaps cover a glabella, which has been slid downwards, and a reach wide nasolabial flap based on the subcutaneous pedicle. Both flaps in place. A few months later, and a few years later, if one doesn't go deep into the bone, just scrape it off the periosteum, you can get recurrences there. Now, coming on to the lip, in my experience, most of the tumors on the lip, on the upper lip, they are BCCs, and on the lower lip, there are SCCs. Okay, so this is a recurrent BCC on the left side of the upper lip. You can see here, which has been marked out. And this is an M flap, as I call it. It makes it easier to close it when you go back. An M flap. That's a defect. And closing layers, mucosa, muscle layer, and the skin. Another BCC on the upper lip, which is being repaired with what's called a steeple flap, which you raise from the side of the nose, the alar base. You can open up the alar base right in there. And then we suture that down. It makes it easier to do that. This is a recurrent BCC of the upper lip. We've had it operated many times, and it returned. And so a very wide excision has done, leaving a very big defect. We used a switch flap, an Abbey flap, to close that. You can see there, that's a pedicle down there, which is divided about 3/4 weeks later. That's pedicle after division, and then you have to do a kiloplasty on the right side. She had further procedures done, but I don't have any pictures of that. All right, coming on to the outer campus of the eye, a large BCC, cicatrizing BCC, as we call it, excised and used a superiorly placed cheek flap. So there we go. Again, this is a recurrent BCC of the outer campus excised. This affected both the upper and lower eyelid, and had to use again a superiorly based flap, transverse flap. So they construct that. I have to repair the conjunctiva first, and then the skin. The flap developed, moved into place. So there's the upper lid component, lower lid component there. This is a few months later. Unfortunately, in men, when you do this, you get hair growing on the flap. But he had to be shaving his eyelid every morning. So I had to bring him in quite frequently to do a epilation. I used point diathermy to de-epilate the hair roots. It's another example of about 3 flaps and 1 skin graft for a patient with multiple skin lesions. Now going on to the ear, this is something we see very often in where a VCC inside the canal of the ear, and they are pretty difficult to treat unless you could radically treat them. If they recur, they go right down into the mastoid. You try and do as much as possible, go in as deep as you can, which is down here. And then you see post-auricular skin as a flap. I call it the trapdoor flap. You see this, an example would be, a nice example would be the string bin pumps. The axis on either side of it, like you see there. So that's then swiveled over anteriorly. So the posterior skin is swiveled anteriorly, and you can see the donor wound flows there. So that's a flap in place. I don't know if you can see it well here. You have to retract the tragus to see that. You do quite a lot of these there. I don't know why they get pieces inside the canal. I have no idea. Still on the ears, you get a larger lesion, like size, repaired with superior base. Post-auricular flap, you can see that. Okay. Now, this is a modification of the Notre Dame tears. I can't see the pointer. So this is a tumor on the upper pole of the right ear, which has been excised, leaving quite a large defect. You continue that, the incision right down onto the earlobe, separated from the skin, the cartilage and anterior skin from the posterior skin, and then rotate it and advance it. So this is the rotation advancing method of anterior for ear reconstruction. This patient ended up with, because it was a large area on the anterior upper pole, he ended up with his POC here, as you can see there. So this one goes further down the helix, so that it was easier to reconstruct this. Again, the same technique, lifting it, advancing it, and rotating it. It's smaller, yeah, but much more aesthetic result. This is a deeper lesion going into the pelvic margins, widely excised, leaving quite a large defect. So to use continuing into the earlobe, advancing it, and bridging the defect with cartilage graft. You can see here, cartilage graft harvested from behind the and then covering the whole thing with the cartilage graft in place there. And so that's a cartilage graft in place there. And that's covered with the post-auricular flap. Now he needed a sulco reconstruction, but he did that's the first stage. He didn't want to come for the second stage. He said he's quite happy with the clearance as it is. Left it. So that was about a year after the first operation. Now coming on to the forehead, there's a temple, small lesion, excised in V to Y advancement flux. 2 V to Y. It covers it, larger retroi on the forehead. This was a chappie who had recurrent SCC, which is going on to the periosteum, widely excised and repaired with a scalp rotation flap. You can see that. So that has been rotated. Periosteum is intact here. No periosteum there, so that needs to be covered. So that the advancing edge of the flap goes on to cover that bit. As you can see here, the flap is placed inside the suture. He came a few years. Okay. This is a man who had a lesion on his forehead, excised by the dermatologist, sent for biopsy with a very thick tumor, and he had put a skin graft on that, and it's needed, and it wasn't completely excised, so he was sent to me, and this is what I had to do: go right down to the periosteum on the forehead, completely excised with a wide margin, and raised flat on either side of the mark here, and the scalp rotated. It moved forward, as you can see here. Now, there was in the 50s and 60s, there was a practice by the radiotherapist to treat fungal tumors of the fungal infections of the scalp with radiotherapy, which in the long term cause skin tumors, as you can see here. And these, they don't do it anymore, but there were a lot of survivors from that era. So they all had these tumors on its scalp that was widely excised. And scalp grafts used to cover the area devoid of periosteum, and the rest were grafted. This patient came to me many years later, and it's a picture for sure surgery we did about 5 years before that. This was a lady who had a BCC recurrent again, which had gone into the bone. What we did was to excise it and burr into the bone. Took the outer table off right down to the diplo. So when it starts to bleed, you know you're right in the right area. So that's the tumor thing. Okay, then we had to raise up the whole of the scalp to cover that the defect, and what couldn't be covered, we put skin grafts on. And this was a few months later. Now, just going on to the nose, as I said, 45% of cancers in the face are nasal. Most of them occur on the nose. So the face is known as the nose is known as the facial sun terrace. That's where you get most of the sun exposure. So just this, I'll go region by region here. So this is the right side of the nose, on the lateral wall, excised, a BCC, prepared with a simple Robert flap. Again, multiple BCCs, one on the forehead, temple, and the nose, both repaired with rhomboid flap. Now, this is coming nearer to the tip of the nose, the BCC, which is in size. This is an example of a bilobe in the flap. So you find the defect there. You need two flaps on the same pedicle. So you get the primary defect exposed with this flap there, and the secondary defect closed with the flap from there. And the secondary defect is closed primarily, as you can see here. Another example of that. Close up, defect there, primary flap and secondary flap. worked in place. Good. We're still on the lateral wall of the nose, and there are two tumors, both closed. One is closed primarily, as you can see here, and labella flap for the lateral wall of the nose. Okay, just a few words about the rhinoplasty that we use for deeper, bigger tumors. And Srishnath is supposed to have done this in 600 BC, that is 600 years before Christ. He was a learned temple priest, because only the priests in those days were educated. So everybody went to him if they had any problems. So he's credited with innovating this and further other surgical techniques. So it has been called Indian forehead rhinoplasty because of this history. So that's what we do now. This is done for whenever you get problems on the nose, you get contour deformity. So that needs to be reconstructed. And the way to do that is to do it in aesthetic subunits of the nose. So this is the picture here, shows aesthetic areas and the subunits of these areas. You get the lateral wall, the ala, the tip, the soft triangle, you see that, and the polymalar, which is just there. So all these needs to be reconstructed individually to restore the aesthetic area. So that's the principle. So it could be the tumors may affect just the surface, the skin, may go deeper and affect the cartilage and bone. So that needs to be reconstructed as well. So it may go further down into the lining, that's mucosa, which needs to be affected as well. So the aims are to excise the tumor, restore the normal function, and restore the aesthetic expectations, which is the contour, the color, texture, symmetry, etc., and leaving minimal mass for in the donor site as well. So you need to use other tissue, transfer tissue there. So the donor site deformity also needs to be minimized. Some examples of that you had a right ala, a VCC on the right ala, the current one has been excised. Somebody had drawn this out to see whether they could reach wire component. He couldn't, so he called me, and then we did the forehead plan for him. And whenever you repair the right ala or the ala, one needs to put a batten graft. And this was done by taking a composite graft from behind the ear, which includes the skin and the underlying cartilage. So that's a batten graft. So you can see it in the underlying cartilage placed in there as a support. Otherwise, you get a pinched appearance of the ear that will collapse. I'm sorry, the pinched appearance of the ala. So that's the first stage. Second stage is to divide it. And the third stage was to thin the flap. And this is the final result. Now the example of a large piece is here on the left side of the nose, near the ala cheek margin, widely excised, like that. It was repaired with a turning nasolabial flap, as you can see here. This is done in stages again. There was no graft put in here in the first stage, because this is among my first case, I think, that we were doing this. So I was very cautious of putting a graft in there. So I got the back second time, took a graft from the place it in there, raise the nasal labial flap, put the graft in there, and then stitch it back in. And this is the result after this. It's very difficult to get this contour where the cheek nasal, cheek area is. But I think this is acceptable. She accepted it anyway. Another one is patient. By this time, I started doing more surgery. I went and did a special course for that to familiarize myself with most surgery. If anybody wants to know what that is, we'll talk about it later. So you do most surgery to make sure that this is a recurrent tumor. So we have to do most to make sure that we are tumor-free before reconstruction. The most surgery excites the whole thing, and that's the defect that is corrected with, again, a battening flap using cartilage down there and an HLA flap to cover the skin. The second stage is brought in for division of the flap and thinning, and this is the final stage on the right side. Again, most surgery here for a recurrent BCC on the tip of the nose, widely excised, and forehead flap to reconstruct that defect. Here I ignored the subunit reconstruction. I thought that it's an overkill for this patient. We just did the left side of the tip. It was quite bulky, brought it back to defat it, as you can see. That's a fat being excised there. This is before the defatting. I don't have a picture. I don't know of the post-operative period there. Okay, so this is it's very deep SCC infiltrating, going right down, affecting all the three layers: the skin, supporting structures, and the mucosa. So widely excised, again under more surgery, and this required quite a complex reconstruction, which was done by raising a forehead flap and using the skin dorsal to the defect. The skin is used, which was flipped over to provide the mucosal cover, which is excised here. The cartilage graft from the ear, from the paper, so that's the whole cartilage, which is there, and you can see the skin from the dorsum of the nose, proximal to the defect, which is being dissected, deepitalized. I don't know whether you can appreciate that. That center there has been deepitalized, and the base has deepitalized as well. About half a centimeter of that. That's the base of that flap. And then you deepitalize that. Right there. But you do all the deepitalization before you raise the flap. Otherwise, it's very difficult to deepitalize it. And then that's flipped over, like so. And the cartilage shaft is then placed on top of that, which will provide the support. So this deepitalized centric bit rests on the dorsum of the nasal spine. So that's the flap, the lining, and the support provided. Now you need to cover the skin. Provide a skin cover, which is done by this, the forehead flap diagonally. That's been raised and inset, and the forehead defect covered with skin graft, split skin. So that's the first stage. Once that's done, you brought back 2 or 3 weeks later and divided and put back whatever you can onto the bed where it's been raised. So that's very good. So that's been excised. And you don't actually excise it, use as much of it as possible. And you brought back for thinning of the flap, which I did. I didn't do all of it in one go. I would do one side first and get it back 2 months later to do the other side, just so that I don't revitalize that forehead flap. So that's the end result. But this is about a year on. Another example is a keratinizing. I think it is. Yeah, again, this is sent by a dermatologist who tried to excise it. And when he excised it, he found he had gone right down to the inside the nose. So I had to do he wasn't sure whether he had done full clearance, so I had to do more surgery again, make sure that we had tumor-free clearance, and then reconstruction. So it's the same technique used. The dorsal skin proximally, dorsal skin distal to the defect, raise the lining, raise the cartilage graft, and the forehead flap. But here you had to provide the polymellar skin as well. So luckily, this guy was fairly baldish, so I could extend that flap right up to his hairline to get the polymellar extension. Flap in place, divided, and that's it. Thank you. Thank you very much.
Thank you very much, sir. Any questions from our audience? Even the online audience can put in your question in the chat box. How is it again? Before we go to the next lecture, we'll, if any questions are there, just put it in the chat box. So, Dr. Krish sir will answer it. So nothing has come so far. Okay, with this, then we'll go to the next lecture of the day. I invite Professor Sathish Kumar to please deliver his lecture on lower limb reconstruction.
I was thinking one of your please have a seat. One of your lecture, one of the videos not for Google hyperlink call Isha hyperlink sends the video now only, not that in between disturbing. So that let there be a break of 5 minutes. There is a one video which is not playing, so that also we will hyperlink. Okay. Maybe the one that I have call Isha. We will take the questions at the end of both speakers' talk in the panel discussion. So now we are going to start with the second talk. Just give us 2-3 minutes for uploading the PPT. Okay, so just wait. All those participants who are online, just wait for 2-3 minutes. Over to you, sir.
Evening, everyone. Respected professors, colleagues, friends, both here and those online. Thank you, Krish, for an excellent talk. I've listened to it before, but every time I have the talk rerun, there are a few additional points that I can pick up for it. Thank you very much. The talk that we are going to see now is perhaps something that's much more familiar to our audience here. India being one of the countries with the maximum amount of road traffic accidents, and in the south, Tamil Nadu has the highest density of two-wheeler accidents, and Chennai, from where I am, even last few days ago, a couple of my colleagues were involved in cycling accidents. So that's the prevalence of what we're going to talk about. Yes, we do get the occasional foot malignancies, we get melanoma, sacral lentiginous, and occasionally, yes, we do get to do some microsurgical reconstruction on diabetic foots. But more often than not, the bulk of our work is related to the trauma that comes through. We'll go to a few points for the sake of our trainees, both in plastics and in orthopedics. And I think this is one of the key areas where we really need the team approach between plastic surgeons and orthopedic surgeons, especially in addition to all of the specialties who can optimize the patient for our surgery, not to forget the anesthetists, the diabetologists, the intensivists, and so on. Okay, so moving across here. Okay, so we talked about those, and the commonest indications is the one on the right, where we have the traumatic foot injuries, distal tibia fractures, or the foot cross injury. The diabetic foot, more often than not, we tend to manage them perhaps with grafts, and of late, we've had the opportunity to use dermal matrices that are available in our country. So there's a lot of use for that as well, where we can salvage without having to do all the fancy flaps that we had in a repertoire previously. Okay. Foot injuries come in various stages. Some of them come to us immediately. Some of them get treated elsewhere, occasionally by allopathic doctors, sometimes even by others. Sometimes what they think is a simple injury becomes complex because close degloving missed, fractures are trying to manage conservatively, tight bandages are applied, and the wound deteriorates further before they come up to the portals of a plastic surgery department. What happens when we get these injuries is more often than not, it comes to the ER, comes to our orthopedic surgeons, who some of them do call us for the initial debridement as well. Occasionally, we are called in subsequently. We'll see what benefits there are if we do get involved early on. Subsequently, there's a debridement, and then we think in terms of what the orthopedic surgeons can do, and subsequently what we can offer in plastics. The team approach, as I mentioned, is not something new. It's something that's been spoken about in Britain for a while, as in other parts of the world. This is something that was mentioned by Simon K. from Leeds, who at one point in time was the president of the International Federation for Societies for Surgery of the Hand. And he spoke about how it's vital to get the plastic surgeons involved as feasible right from the word go. And we can contribute significantly to how these persons get rehabilitated. And ideally, we want to provide them a definitive soft tissue closure within about 3, at the most 5 days. It's not a good idea to keep these wounds festering for long. Okay? So what we do initially is do a thorough debridement, and this debridement I feel is much better done under tourniquet with good magnification in an operating theater by a plastic surgeon. There are those who might tend to disagree, but it obviously depends on training, what you're used to. But this needs to be literally akin to cancer surgery. And if you do a good debridement, that's actually most of the battle conquered. You can't do a shoddy job of the debridement and then expect an excellent reconstruction on top of it to work. It will fail. Sometimes it might seem to heal the flesh wound at some point in time initially, and then later on you will get non-unions, sinuses forming, osteolytic areas. So it's vital that a thorough job of debridement be done, and with a tourniquet with magnification, perhaps loops. And we often find that the pulse lavage system is very useful, perhaps not initially because it tends to create a lot of foam and masks the contaminants. But at a later point in time, to get the microscopic contaminants away, it's really essential to use pulse lavage. That does seem to help significantly. And if you do that, you do a significant job in improving the rehabilitation of the patient. And that elderly gentleman you see was the one who had that bad crush injury. And let me see if this video works. And that's him literally walking around in normal footwear. He has just one metatarsus, the first one, but you've got a good muscle flap to cover it, and he's okay with a slight modification in his footwear, good ankle movement, able to weight bear, and you make sure that quite a bit of our patients are diabetic as well. And the more you spread the weight, the wider the area you can offer them for weight bearing, the lesser the chances of breakdown in the future, and lesser the chances of further amputation, either in that foot or the contralateral foot as well. Okay. As far as skeletal stabilization is concerned, there are umpteen versions of it. You can have the commonest being the AO frames, either uniplanar or multiplanar. Those would be the most soft tissue friendly. The most disruptive for a plastic surgeon is the Ilizarov frame. And we usually try and resist the orthopedic surgeons move to put it on. We understand that it is great for skeletal stabilization, that you can have it as a definitive form of management, but it does significantly hamper our ability to work on the soft tissue, and it's not something that we would favor. Not to mention that the fact that the sharp end of the cut wires often tears your forearms and hands as well. Okay. And the reason why I feel that plastic surgeons should get involved is it could be something as simple as this: a foot injury, just a couple of shunts when Ilizarov half frame, and you can have good control of the ankle. You can control eversion, and subsequently, as you can see, you can suspend this limb in the air also, so that, for example, if you have a heel injury, you don't have any pressure causing further damage to the soft tissue there. The reason why it's good for us to get involved is depending on what your plan is going to be. For example, if you're planning a free tissue transfer and if you're thinking in terms of the posterior neurovascular bundle for your wrist vessels, you will ask them to swing the fixator more anteriorly. You have a 30-degree arc with which the the orthopedic surgeons can put the transplant. And so if you're going towards the anterior tibial, you'll ask them to put it more medially. If you're going towards the posterior tibial for your venous, for your vascular access, you'll ask them to put it anteriorly, and that will make sure that your microscope can come in close and you can have an unhindered feed. So it's nice that you're around at that point in time during the debridement and during the skeletal stabilization to be able to get them to do this. And subsequently, if you feel that the soft tissue can be compromised, you can also have elevating frames, either box-shaped frames that can be attached with rotor rod clamps on an AO frame, or even on an Ilizarov ring. So the fixation itself is not the Ilizarov. It's just that the Ilizarov frame is there to suspend and elevate it, and you can have a very comfortable person who can sort of externally and internally rotate his foot and move it about well, and the limb is automatically elevated so that you have edema control as well. And all you need to do is to loosen a few nuts and you'll have full access to that area doing your soft tissue surgery, and it's like protecting. It's like a foot wall around your house. So once you do a free flap, if you have this, you can sleep much better at night knowing that your flaps are going to be covered. No one is going to be able to get to your flaps or move a joint in close proximity to anastomosis and cause jeopardy to your flap. Okay, so these are some of the things that we do. Often initially we used to have only these proximal frames, and then one clever patient flexed his knee and then rested on the heel component and killed off a little of the free flap. Then we realized, okay, we'll have extensions there and make it idiot proof, so that whether the patient likes it or not, our flap has to survive. At least till we get good pictures and be happy with it. And then it's up to him to decide how he wants to abuse his limb. But as long as he's with us, we've got to make sure that irrespective of his wishes, we've got to make sure that he gets a good outcome from our inputs. Okay. So this is the box frame, not as convenient as having a Ilizarov ring, which gives you that much more mobility. Okay. We all know from Godina that we need to go in early. And if we go in early and start with the debridement, then it gives us an opportunity at the end of surgery to start counseling the relatives, because finances are a big part of most of our daily work. Perhaps not in Central Institute, but in private practice and in the private medical colleges. So it gives us an opportunity to be able to counsel them as to what the long-term plan is, the financial outlay, and the time duration that the person may have to spend in hospital or away from work. So, because most of these are in the productive age group, young men perhaps, and we need to give them some guidelines as to when they are going to be able to get back to either studies or work. Okay. Negative pressure wound therapy. This is something that we are fairly happy to use these days. It tries to keep the area edema free, and also to a very great extent, it prevents migration of the bacteria proximally along the neurovascular bundle, and that makes dissection that much more difficult. If you leave the wound for longer, if you're forced to for various reasons, if you have negative pressure wound therapy, the bacterial load and the dissection of the recipient vessel is much better than if you do not have it. Obviously, a good debridement is paramount, but on top of it, if you need to wait for more than 48 hours or so, then it's not a bad idea to put negative pressure on at that point in time. You don't need to do any dressings post-op. Patient will be pain-free. The fluid, the smell, everything is taken care of. Your wound is cleaned till you get the patient optimized, and then you can open the dressing in OT and then proceed with your soft tissue cover. Flap selection, I think there's no particular need. Previously, we used to have this big debate as to whether a muscle flap is useful or a fasciocutaneous flap. All flaps have enough blood supply. That's how God designed these tissues. It really doesn't matter as long as you can get the dead space obliterated. I think that's perhaps more important. If you have a very irregular contour in your bed, there's no point putting a fasciocutaneous flap which is going to leave pockets inside of hematoma, which could potentially get infected. A muscle flap obviously will do better in those situations. A fasciocutaneous flap is okay for surface areas where you want good skin insect. If you're planning further date orthopedic work, obviously for someone, if you're not going to be there, if you are around, you can lift up a muscle flap, not very difficult. But if someone else is going to be able to do it, it's nice to have a dermis to dermis saline edge so that the orthopedic surgeon can lift and put in a bone graft, for example. Again, when it comes to the sole weight-bearing area of the foot, if perhaps your patient is in the Western world used to footwear at all times, then perhaps a fasciocutaneous flap will work. But if you think that perhaps at home they may walk barefoot or may not always be okay to your idea of having footwear at all times, then perhaps a muscle flap which will stick onto the bed, onto the sole especially, is more useful with a graft than a fasciocutaneous flap, which tends to shear, and the subcutaneous flap will tend to have bursa formation. I'll show you some images at a later point in time. So whether it's muscle or fasciocutaneous flap, I think it's more a component of what the wound predicts, the area, and to a certain extent, the surgeon's preference as well. We use multiple choices. Initial stages when we were doing rectus flaps, obviously we do not deal with rectus now. You need mesh to cause weakening of the abdominal wall. There are situations when previously, prior to ALPs coming, we used to use radial forearms, even with a small skin island as an adipofacial, so that you don't have a donor deficit with your FCR poking out. But those, I think, are overkill now. You wouldn't want to waste a radial artery on a foot injury. You wouldn't want to waste rectus abdominis for this when we have so many other better options in this point in time. So muscle flaps, yes, lat dorsi, gracilis, common options. Vastus lateralis, if you go in with, let's say, an option open-ended, whether if you have a fasciocutaneous or a muscle flap, it really doesn't matter. Then if you do not have perforators to support your ALT flap, then vastus lateralis is perhaps an option. But otherwise, it's not as easy to harvest as gracilis. It is a little bit messy, lot of diathermy dissection, so it's not something. It gives you a lot of volume of muscle, agreed, and it gives you multiple components. You can have a facial component with it, you can have a skin component with it. So there's a particular need for a kind of turmeric flap, then yes, that's useful, but not per se from the point of view of pure muscle, it may not be the easiest one to have. Okay. Gracilis is very good that way. The disadvantage with the gracilis is if you have a small defect and you want to take your pedicle anastomosis away from the defect, gracilis having a short pedicle and a big muscle close to the pedicle, you will have to lay that area open to do the anastomosis. But if you have vastus lateralis, your pedicle is nice and long, you can actually tunnel it subcutaneously and keep it elsewhere and take as little or as much of the vastus lateralis as you particularly want to fill up that area, especially for field defects for cavities. Okay. So this is just some examples, either using a gracilis or vastus lateralis, so you can poke it into the hole, take the pedicle further proximally, so that you get a nice volume fill in that particular area of the defect that you want. Rather than, for example, if you're gracilis, the bulk of your muscle will end up here, and you'll actually very little of the muscle coming up in the area where you really want it to be. So it's more a question of how you shape the amount of tissue that you take out. And then always remember that muscle flaps is very important to counsel the person to have compressive dressing, because otherwise it becomes edematous. You're not flapping any lymphatics, you're only doing a venous anastomosis. So it's important. You would assume that these muscles being denervated atrophy, but if you do not allow the dependent edema to go away, then that works. You'll get a good contour of the muscle. But otherwise, the muscle in itself can become really swollen. It's just something similar to the filateral limbs that we see. We can really become ugly, and every time that person walks into OT, you'll probably want to jump into that thing close by, because it looked that horrible, and you'll wonder why you ever put that flap in place, and perhaps you'll be happier if the flap had not survived. Okay, so that does happen, unfortunately. Okay, so that is the of a flat muscle, wider area, great choice. So muscle flaps, as long as you have a person who is to comply with post-op protocols, good supportive footwear, and good compressive bandages, either a crepe bandage or compression garments, you will get a good contour. And at times we've seen muscle flaps become really thin. It will look like perhaps just normal skin that you can pinch. So much atrophy can take place as well that you can literally start folding it onto itself. That happens as well, and then you'll want it to stay there. You'll want some bulk in the muscle to support, let's say, the calcaneum, but it will just thin out, and you'll have a trophic ulcer developing in that area. So you've got to warn your patient that you need the footwear to support the muscle and keep it under the weight-bearing area, because unfortunately these do not have the fibrous septic that a normal heel pad fat will have. So there's nothing to hold it in place. The more pressure you give, it will tend to swing away on all sides. So TLT, dorsum of foot, a good choice. You can make it thin. You can take a little bit of extra facial later. You can do your exercise attendant reconstruction if you want. Pre-op, it's not all that you need the angiogram or a Doppler. If you suspect vascular injury, yes. Otherwise, just your handheld Doppler or pulse oximetry will be more than sufficient to know the vascular status. And you can check whether your blood vessels are on antegrade flow. For example, if it's the limb, you occlude one vessel, check the flow in the other one to make sure that all the vessels are antegrade flow. So that when you're going in for your anastomosis, you know which vessel. If there's a problem, then if there's a vessel that's gone, and if it's a single vessel limb, you don't want to jeopardize the main flow to that foot. You want to make sure that you go to the area where there is a problem, and perhaps you can even use a flow-through flap if that's what the answer is. So unlike head and neck, on the extremities, we usually prefer to have a end to side anastomosis for the artery, because you don't want to compromise on the vascular flow. Venous anastomosis can be end to end, that's fair enough. But on the arterial side, we always do end to side. The patency rates are better compared to an end to end anastomosis. Flap lock, obviously, none of us like it. And unfortunately, irrespective of how many free flaps you've done before, people judge you by how well your last free flap performs. It's like any sport, for example. You could have had an excellent track record, but if you do badly in one test match, and that's it, you'll have all the world slinging mud at you. That's how it is here as well. And it's very difficult for any surgeon to accept that there's perhaps nothing he could have done to make it work. You always try to think in terms of what could I have done to make this flap also work. That's how it is. Okay. So thinning of flaps, especially an ALT, even if it's thick, you can dissect through the fascia and make it as thin as possible using the perforator dissection we have. You don't necessarily need any chunk of muscle with it. You can also, if it is not a subcutaneous vessel, you could skeletonize the vessel through the muscle as well. All you need is a little bit of warm lidocaine to paralyze the muscle around it, the nerve, so that it doesn't keep twitching, and it's simpler to dissect the vessel. It's sometimes very easy to think you're following the vessel, but to go off tangent if you have a cup of muscle. So people sometimes feel it's safer to have muscle and that the vessel will go through it. But these vessels, unfortunately, don't go from point A to point B. They have devious routes in between, and occasionally you can get trapped in those as well. Okay, so if you thin the flap, you can get good results. But if you want to be safe, you could always do the thinning subsequently as well. Donor site wise, most often you'll be able to close a reasonably wide donor site primarily in an ALT. You can use intraoperative tissue expansion. As soon as you harvest the flap, you put in some tight sutures. So creep and intraoperative tissue expansions and sometimes work, and you'll be able to get away with the primary suture line rather than a graft on the site. The variable anatomy is something that not everyone likes. It's not as standard as LP or Gracilis. You do have some variations in the vascular anatomy here. If you have ability to get MDCTs, or you can get your radiologist to Doppler vessels and tell you at least where the good perforator is on the skin, like everyone does for Dept flap in the West, it would be good. We do try it at times, but sometimes we get good results. Sometimes what the radiologist gives is not particularly what we find helpful. There's a good vessel, but it's only an artery. The veins are not very good. So even if you have a good Doppler signal, even if you have some input from the radiologist, you do need to be careful that you look at the vessels per se and follow them backwards. Muscle flaps, it's important to try and get these to spread out, put it under slightly more tension than the resting tension of the muscle. You stretch it out, and the little bit of extra tension helps the flow of blood in the muscle as well. And underneath, we used to use small kin paddles to monitor, but nowadays we don't particularly monitor with the skin paddle on top of a muscle. It's okay if your team is used monitoring a muscle directly by poking it rather than scratching a dermis, or you could have any of the ancillary. If money is not a concern, you could even have an implantable Doppler if you so wish, so that you can continuously monitor your flaps. There are times when we feel that, okay, there's only so much we can do. It's a little bit like an Australian chap who had cramps in his leg. He would hit the ball and then wait. If it crosses the boundary, his team gets some runs. Otherwise, he'll just be standing still. So there are situations when you'll have to do that with your free flap also. You're the only person. If you've done the question, can't, then say, can we monitor the free flap? Heaven's sake, no. I don't want you to ruin my night or my weekend. We'll come back on Monday, have a look at it. If it's fine, we'll all go out for a treat. If it's not, we'll all go into morning. Okay, that does happen at times. Obviously, these are not for the postgraduates to mention in an exam. Okay, so I'm sure will bury me before I leave Pondicherry. But at times, in a clinical situation, when you know you've given your best, there's nothing more you can do. You may have to accept it. I'm not saying it as a routine, but for example, a replant, a difficult replant, you give it the best. If it fails, it fails. There's not a lot you can do to come back and do anything more. Okay? So always try and insert the muscle flap. Lift up the surrounding skin edges, tuck it inside. The contour is much, much better than allowing it to contract. And also it's important to make sure that your muscle flap does not come away from the edges, because if it doesn't contract and then you have a small area there, it will eventually epithelialize and heal either with or without a graft. But the muscle contracting in looks like a mound. I'll show you some pictures later. this flap. Obviously, the patient is unhappy, you're unhappy, and you're wondering why you didn't thin the muscle or you didn't push the muscle under the skin edge there. And it's very important to lift the edge, tuck it underneath so that sometimes you find that the leading edge of the skin, which your debridement is not perfect, goes, or the edge of your muscle will revascularize. So there's a bit of an overlap. Even if one doesn't do too well, the other will compensate. It's like double breasting of your foot. So you're not going to have naked areas in between. Similar principle for a muscle flap also. Try and tuck in the leading edge of your muscle flap on all sides, that's much better. So various components we spoke about the sole reconstruction, vastus latalis, so that the entire sole seems to work well. You get a nice broad muscle coming across. You can fan it out to cover the weight bearing area near the metatarsal heads, and you have a good support on the heel pad as well. Advantage with the vastus is that you can take the fasciolator on a separate axis, sometimes get it through the metatarsal heads, and if you need dorsal foot coverage, you can use the fascia to cover the dorsum, put a graft on top, and you have the muscle on the plantar side to be able to graft across there. You could get shimmeric components, a skin paddle separately, muscle paddle separately. You could position them wherever you want. And that would be an advantage when you have the composite effect. Impaling, occasionally, more often than not, we get our orthopedic surgeons to put pins in through areas of intact skin. Sometimes it's not possible because you won't get any fracture stability. You've got to keep your pins close to the fracture for them to be able to hold the bones well. And you want the bones to be held well because if they start moving, then they will pull up your flap and tear your anastomosis apart. So it's a conflict of interest. We would like them to keep their pins as far apart as possible so that it doesn't come in the way of a flap. But if you need to do it, one simple option is ask them to put a double rod. So you take one rod, impale your flap on it, and then put the rod back on again, and then take off the rod that is lower down and let it slide. As long as your rods are parallel, your flap will just slide down and come down and rest on its bed. So you don't need to disturb the shank spin at all. All you need is two rods to impale your flap through, and you'll be able to get your flap, either feature cutaneous flap or muscle flap. Without disturbing the fracture site and the fixation, you can get your flap to cover. So you don't need to go around shank spin. You can actually go through the, get the flap impaled through the pin itself. Okay? And this is not a comfortable experience, but you still can make do with certain components of the Elizarov ring. Obviously, you can't do anything to the tensed wires, because the minute you cut half of it, the tension goes and the entire principle of the Elizarov works. But the surrounding ring, you can take away some of it and get to work within the depths. If that's the only option you have, we have done it on occasions where you put a free flap with an Elizarov construct as well. Stump salvage, either for a Biloni stump or a 4-foot stump, you don't need to necessarily sacrifice a joint. You could use free flap, either from the amputated part if there is, or free flap that you harvested elsewhere to try and salvage a stump. The zone of injury, most of us think in terms of just what we see on the surface. Unfortunately, that's not always true. This particular wound, our orthopedic surgeons were very happy. They knew that we love tissues, and the orthopedic surgeon said, I knew that you'll be very unhappy. So we've taken that entire muscle and shoved it back into here and said, you kept it all for you all to see. We didn't know whether we should thank him or not. He said, that's fine. Thank you very much for thinking of us. Even when you're doing the debridement, you all were busy, so we had to do this. So imagine, so if you go for a vessel here, the muscle has been pulled off here. So you've got to make sure you have an angio. You've got to make sure that the vessels are okay before you start harvesting your teeth. And some orthopedic surgeons are really kind like this. Some, okay, not perhaps. I'll just go back to the other one. This particular one was a shank spin impaling and crushing anterior neurovascular bundle. And unfortunately, this was okay at that point in time, developed a pseudoaneurysm, and 10th day it started bleeding. So the flap was okay, perfusing, but proximally from near the pin site, the person was oozing. So we had to go in again, clear out that segment of the vessel and put in a vein graft. I'll come to that. Or you could have a situation like this. the wound is here, you want to do your anastomosis here, but there's a proximal fracture also. So the fixator is there, but you need to be aware there's a proximal fracture and what's happening to the vessels in that area, especially if you're going for the anterior reticle. It's close by. You need to know what the status of the vessel is. So dissect it. Maybe in these situations, get an angio, get a venous Doppler, try and get as much info as you can before you go in for your free tissue transfer. Okay. So we've seen this. So if you have no other option, okay, ideally you'll go proximal to the zone of trauma. If not, sometimes you can go distal to the zone of trauma. And occasionally, if you have no choice, you may have to go within the zone of trauma as well. Okay. I was talking about the vein grafts that we use. So this was one such situation where you had to use, we had to take out that pin, relocate it, and then get a vein graft to bridge the artery and the vein. As you can see, my judgment of the artery length was slightly off. We can see that it's a little bit more. It should have been obviously because the pressure in the artery is more. You need a smaller segment of vein to be able to cope with that. But artery that way a little bit fulfilling. Even if it's slightly longer, it will still sort of unfurl and flow through, as opposed to a vein graft, which will tend to kink more easily. Okay. So distal anastomosis. This was someone who had a custom metaprosthesis, had an issue with wound healing. The prosthesis had to come off. An external fixator was put in temporarily, and a distal anastomosis was done. The anastomosis was distal, but the vein has still to be given proximally. Artery, if there's distal pulsating flow, you can give it either to the proximal or distal end, but the veins, you've got to make sure that it is flowing to the heart. You can't anastomose it on towards the foot away from the heart. Obviously, the valves and the system is not going to work. It will be like an RSA flap which gets congested. So you've got to make sure that your veins are anyway flowing through the area of trauma. The artery, perhaps, even if it's on reverse flow, it can accommodate. Then subsequently, the fixator was removed and the processes which was kept safe. This actually was costed a lot. It had come from Britain and it was for a young person. So this processes has the ability, you see the screw here. So as the child grows, the processes then can be lengthened to compensate intermittently for the growth of the other limb. So this was an expensive, valuable processes, and we managed to get it back in at a later point in time after doing a pre-slap with a distal anastomosis. Okay. Occasionally, you are forced into the zone of trauma. In this, there's no way you can get long segment vein grafts or go proximally or get a correlate loop through all of this. And what you sometimes think is a wound, it's more on the surface. This is inside may actually be okay. So it's worth going in, looking at the vessels. And this is what Eisenberg and Huntington say. If the vessel area around is easy to dissect, and if you can get milking of your veins is possible, and any side branch, if you do a small arteriotomy, if there's multiple pulsatile flow, then it's okay to go in and do an anastomosis, even if it is within the zone of trauma. So we can do that, and a few examples of that. So proximal thigh injury, a badly mangled foot. This child was run over by his school bus, so we had to get this dorsum of foot sorted out. Okay. So we spoke about the problems with using a fasciocutaneous flap. This was a radial forearm done long ago. You see the ump of bursa fluid, the swelling that comes up there. Similarly, this is latissimus dorsi, this intact skin on the sole, which was distally eglet, was put back. But you see the fact that the septae are not there. You see the big bursa that's forming in there. So it looks okay here, but that's the big bursa that is forming inside because of the curing that is taking place, because there's nothing to anchor whatever you're putting onto the calcaneum. It keeps curing. If you don't have appropriate footwear, this is one of the problems that happens. Okay. Rehab, we spoke about good footwear and good compression garments. Especially in kids, it's vital that we give them good flap cover, because otherwise this was a flap from the thigh that was taken onto the dorsum. Unfortunately, it failed, and you see as the child grows, how the distortion is taking place at the ankle and the foot. So we don't want that. You need can give. So even if there are tiny kids, it's not particularly difficult to do these anastomosis. It may be slightly more difficult from the anesthetic point of view to get these kids to be stable enough, but even 20, 30 gram flap work well. You probably need to put fewer sutures, and their blood vessels are so forgiving. Unlike adults who may have comorbids and thick vessels, their vessels are much more pliable and a pleasure to work with. You can get them to work. And as long as the kid is happy and you make sure that you don't hurt the kid, so even dressing changes, we tend to do it with anesthetic help so that they're not fearful of coming to the hospital or seeing a doctor. They are happy to cooperate with you. But even with that, you see the size. This was a long flap, which was literally the scar initially was near the iliac crest. As the child grows with keloid formation and with growth, it's really become a tiny scar. And sometimes you find that the flap is okay, but the border between the flap and the native skin, that scar tends to tighten up. You may need to incorporate some jet flasties in that subsequent case. We're all aware of the reconstructive ladder, reconstructive elevator, and we know about the use of negative pressure and dermal matrices. But I would think the more important concept now is the reconstructive toolbox. It's not like you can only use a local flap or you only need to use dermal matrices or a free flap. We could, as plastic surgeons, use a combination of all of this. It's not that one is exclusive to the other. A ladder or an elevator gives the impression that you can only stand in one level at one point in time, either on the fourth floor in the seminar hall or you're in A&E on the ground. So you don't necessarily need to be. You can be in plastic surgery OT, you can be in ER, you can be in the library, all at the same time. Okay, so that's where I think we should be thinking of that particular area. Let's tailor make what is most appropriate for healing in that particular situation. Okay? Gone through all of this, there are some things that I'm very sad to say is happening in plastic surgery, and I think we're probably going to be less useful to the world than we are currently, and that's with the dermal matrices. And I'm sure if there are orthopedic surgeons, general surgeons, they'll all be very happy that, okay, you don't need to waste befriending a plastic surgeon. Here are simple things that I could do and talk to them and say, to hell with your flaps. I can do it. I can cover it as well as you can. Okay. Unfortunately, these things work. It's now available in our country. It used to be available globally for more than 2.5 decades. Unfortunately, it's available in our country as well now, and it's come in with a lot of support. There are multiple companies pushing it for all the wrong reasons as well. That's how the free market is. So this is an exposed tendo Achilles covered with a dermal matrix. That's the dermal matrix. This is a bilayer layer matrix that's been available in the market since the 90s. Okay, and you see the matrix. This is totally acellular. So unlike a skin graft, which needs to have blood supply or plasmatic inhibition to be able to live, these don't. They'll just stay there. As long as they don't get infected, they are willing to stay there. It can take 3 weeks. It can take even 6 weeks for it to gradually vascularize. They are happy to wait. Happy to wait, vascularize, and then all you need to do is a skin graft. How sad is that? Okay, so all you need to do is just a skin graft handle, and you can cover exposed tendon, which we couldn't. Even if you look at our textbook, you'll say bare bone devoid of periosteum or tendon devoid of peritoneum. And if you say I'll put a graft on it, you'll say, hey, you don't get your MCH, or you don't get your DNB classic. Unfortunately, that's true now. You can get bare bone, you can get bare tendon. The only saving grace is that you can't get metalwork covered with this at this point in time. Thank God for small mercies. If that also comes, we can probably shut down our various departments and go home. Okay, and that's the matrix vascularizing. You see how this is a meshed matrix, so it becomes peaky in color. Okay, exposed tibia, long segment. Shows degloving. What flap do we need to offer? Anyone? Anyone from plastics here? Postgraduate? Rectus abdominis. Wonderful. I wish. Okay. So this person did not want. So this is obviously not a rectus abdominis. This is just a matrix. And this is all of the tibia, literally from the knee till just above the ankle. and see what happens. Gradually, the matrix is vascularizing, and that's it. Healed. Okay, there goes nice rectus. There's no need for rectus anymore. Okay, and to top that crush injury, there was no fracture in that. Look at this. There's a fracture here. A small butterfly fragment has come off. You see that bit there? This man was very sick. He couldn't offer anything. So in our ICU, they said, if anything else, you can put the matrix, it's likely to go. And probably in 48 hours or so, there'll be pus collecting underneath. And they had some money, so they said, okay, we'll put a vacuum dressing, we'll put a silver dressing also, we'll throw all our cards there, but it needs a flap. Eventually, it will come to us. Now that you've said he's very sick, this is what we can do. See what happens. Fix up, and it's healed. There's still only an external fixator. It still needs a nail. But for now, you've got the wound to settle and heal without any flaps. Okay. A crushed limb. What do you do with this limb? Chop it off? Mostly, right? Okay. This chap was otherwise okay. The CPK, myoglobin all over the shop. But foot was viable. So you can't take it off. This has got a segmental fragment. You see that? The distal fragment here is covered inside. The proximal fragment is all open here. Entire tibia is gone. That's the anterior tibial neurovascular bundle. All the extensor tendons are all crushed, hanging. Very keen to retain. They said at any point in time, this may need to be amputated. There's no guarantee that they can keep it because it's a bad injury. If your kidneys are going off, if you're going to become systemically unstable, you need to chop it off. But we can try. So a combination, a local tibialis anterior flap, the exposed tibial anterior tendon was covered using a matrix, and this dorsal, the anterolateral skin that was distally based was used to cover the extensor tendons that were all crushed here, were just tagged in and attached to the proximal end. And this is actually the neurovascular bundle. It was still pulsating though, covered, and see what happens with the matrix. Okay. So in certain situations, you can get away with very little as well, very little effort, and all you have to show from the point of view of donor side is probably an SSD. And that is not a thick SSD. You need epidermis and a little bit of dermis. That's all the matrix asks for. You can cover. But the only thing you can't do with all of this is lift it if you want to do further body work. Okay, in those situations, you still need. I'm not saying that's the answer. You still need, if you want good robust cover, if you want to fight infection, you still do need the flap. It won't bring the blood, it won't bring the white cells, it won't bring the immune globulins, it won't take your antibiotics through. But in situations where you can't offer any of those, you still want to cover, you should be a good plastic surgeon to be able to do this. You need to be able to do a good debridement. You can't say, okay, I'll just hash of it and cover it and put all this on top and expect it to work. It doesn't work. So you still need a strong foundation of all the basics that you're picking up here to be able to do just the right amount, not too much, not too little to be able to get away. And obviously you need to have nature, God on your side to be able to get all this. It's not that you can guarantee anything in that. Okay. If you want me to continue for another 5 minutes, how are you all playing? Okay. 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 This is a little bit, I thought there will be orthopedic surgeons. So these are two patients who are on our ward currently. Okay. The last week I got these references. Okay. Long tendoachilles. This is how ortho usually tends to approach the DA. Long suture line, and they would either have a direct repair or take FHL or peroneal tendon. They'll work their magic on the tendon, and then finally the tendon gets exposed. Tendon gets exposed here. Then reference comes to plastics. We all have such problems too. You all see lots of exposed PAs. Okay. So, and we've had this as well. This was done in Bengal somewhere. The tendon is gone. The entire soft tissue there is gone. We've had to do ALT with vascularized fasciolata to be able to provide the soft tissue cover and tendon reconstruction simultaneously. And we put a couple of chance pins and elevated it so that there's no pressure on that. Okay. So that's the extent we needed to go for repairing a DA. And this was a close PA rupture, an attrition rupture. So what we tend to do nowadays is, okay, this media doesn't work, but this is basically just demonstrating the Homan sign. Squeezing the calf, this boy happens to be an orthopedic surgeon. So if patients come to orthopedic surgeons, they operate. If the orthopedic surgeons themselves have an injury, they come to plastics. That's the world, okay? If you have small injuries on the face, most of them, the Max Fax team will operate. But if the Max Fax surgeon has an injury or someone really critical has an injury, then that's when they remember there's some jokers called plastic surgeons involved. Them will probably heal the wound without scars, okay? I'm sure that happens all over, okay? So this chap was playing football, got kicked with the football shoe, and that was the area where it was injured. Okay. On table, we use a Doppler. If necessary, we get a radiologist also so that we know precisely where the cut end of the tendon is, what the quality of the tendon is, proximal and distal. We'll also usually get MRI to know that there's enough distal stump to be able to do a direct tendon repair, or whether we need some suture anchors to anchor it onto the calcaneum itself. Or if there's a big loss, whether we need something, a fasciator, or a plantaris or anything else to interpose, or maybe even a turn down TA turn plastic. So we can get a radiologist to help us with that. Okay, here you can actually see the ends of the tendon, not far. There's a little bit of hematoma. The video is not running, but I can show you a little void there. Okay, so make a little cut, expose the ends of the tendon. Once you do that, we always nowadays tend to do a proximal, like a deviate lengthening that we do for FT injuries. If you come up late, the muscle is contracted, you do an intra-substance lengthening so that your fingers not hook the end of your repair, you get it out straight. Similarly, we incise just the gastroc component of it so that you get an additional length. You don't need to immobilize the knee. And after your repair, you're going to shorten it a little bit anyway. So you want a little bit of additional length so that you can get your foot in and neutral. You don't have to worry about an equinus. Okay. And that's his suture line after a post PA repair. So on proximal lengthening here, a couple of stab wounds. Okay, this again was a video with him. First dressing change. You don't need to worry too much what's happening to your suture line. You can ignore it. This was first dressing change after 2 weeks. You know that you've not cut much of the skin for it to necrose anyway, and the incision, as you can see, is on the medial side. Our TA repairs are all done with the person supine, not with the person prone, and we incise more on the medial side, so that when they're lying in bed with their limbs externally rotated, you are offloading that area. You have a little bit of cushioning proximally near the knee, distally near the ankle, so that that area, whatever flow is coming from the peroneal vessels also is not hampered. And your posterior neurovascular bundle, in case you have any tightness in closure, you can release it subfacially, like doing pical flap. Only thing is you're not cutting the skin. You're going underneath the fascia, leaving the perforators, incising the septum between the superciliary and deep muscle compartment, and allowing your skin to slide a little bit so that you have good healing. Okay? So that's done. And that's in full weight bearing. Okay, that was him walking. So all you need is to prevent resisted flexion. You can't ask him to go on tiptoe. You can't ask him to run up a flight of stairs. But with the TA repair, if your TA is okay to take neutral position at the end of surgery, you can go ahead and do. And one of those videos, I actually tried to push it into dorsiflexion on table with the person anesthetic. So if the TA is going to fail, that's the time. Like any tendon repair, if there's a failure, if your free flap is failing, you want it to fail on table. You can sort it out immediately. You don't want that to happen few hours or few days down the line. So if the tendon is going to rupture, you would rather witness a rupture and redo the whole thing again. So what we tend to do is, this was a wound that came to us many weeks later after attempting primary repair elsewhere. The wound had raised and the tendon had retracted back. So this is the incision that we made. This video of it running while pulling with the ethibond here, you will realize that about 1 to 1.5 centimeter additional length you will get once you do the tenotomy there. so that you can do a comfortable closure. And if you can't find the tendon ends there, or if you want to take a Kessler, what we tend to do is to not open it up zigzag or longitudinally. We go through there where the area the needle comes out, we make little stab incisions. Come out there, go in again for your modified Kessler force strand, so that you don't have big suture lines right over the repair site. So 1, 2, where the proximal end, the suture exited and entered again. Similarly on the distal end. So you have, it's like a MIPO technique for both. Okay, the tendon is just there. You don't need to actually see the tendon. You can palpate the tendon and go through, come out in areas, okay, akin to what the lab surgeons done. And this is all part of the AO techniques that are available. So you don't need to make large incisions to open up and see the entire tendon. Okay? So this is just a close-up. So this is actually the wound there. The tendon end has come in there, but the suture is exiting out. So this area, you make a nick and get the epibond inside so that it's not protruding out through the skin. Okay. And if the tendon has retracted and you need a turn plastic, then you can get adequate length. A distally based TA turn plastic can be used to provide the cover as well. If there is a wound across there, you can still do this with a soft tissue cover at the same time. This is RSA flap, which you can use to cover. And when you're raising the flap, you can make sure you get either a turnplasty or a TH anatomy. You can do your tendon work, raise the flap up first with the nerve, and then do whatever work you want to do on the tendon and use the flap to cover that area as well. Okay, you can actually see the anatomy there and the tendon repair going across here with the flap that has been raised with this cover. Okay. Thank you.
Thank you very much, sir.
Thank you.
Thank you very much, sir. Now,
There was a call for Dr. Padma Lakshmi, so I was just seeing her off. So really, it was an extensive series of skin malignancies as well as the leg defects, and I'm sure that the participants were noting down those points which in day-to-day reconstruction help us and help you out also. So now we would like to have a panel discussion. So we will take the questions in the chat box, and physically those who have any doubt or wants to take any point to be clarified, you can ask now. So there is a hello, there is a mic here. Physical people can ask hello. So we will take the questions online. There is a question in the chat. One question I can see. Okay. Dr. Venkatratnam, our close friend of mine from UAE, and he is asking question for the previous speaker. Who can see, how about rounding corner of the limber flap? Dr. Krish would like to take your question. Give the mic to sir, mic, and sir, and focus the camera on the Dr. Krish. So, sir, there is a one question from Dr. Venkat Ratnam. How about rounding the corner of the limber flap? What would you like to say?
Yes, you can do that. I have done it not on the plate. I don't usually do it on the plate because the acidic clearance is not basic. The surge is not very good. But I've done it in other places. I've done it on Back, large treatments of used, right? As well as the axilla, I use that very extensively for high stuff like that. Yes, you can. The short answer is yes, it can be done uh, around the square, around the square.
Okay, sir. We do agree that yes, when it required from aesthetic point of view, we do
I wouldn't do it from an aesthetic point of view.
also from the
It could be on a face, because mostly if shown you here.
with a malignancy.
Yeah, I wouldn't do it.
Okay. So that is what Dr. Venkatadram also has written in continuation of his message. Any other question? Professor Vijay Kumar wants to have a. Yes.
I would like to know experience on how is the weight bearing if we put it over the calculator? Like not the backbone. Some soft tissues there, clamp fails or pre-clamp or RSP just meets there and some varicose ulcer is there. How does it really work? Because I have used on burns and when it does well, sir. But I'm having questions on it. What's your experience?
I'm not including the picture here, but we had an agreement with a critical limb ischemia with calculin and osteomyelitis. We literally most of the calculin is shaved off. Young chap is just in a great phase, was very keen to preserve the limb. So one, the vascular limb is the angioplasty, and there's some sort of something we nibbled off that bone. We put IDRT on it, active dressing and a vacuum dressing. It vascularized over. We put a graft on it, so the limb was saved then. We suggested that we offload that area and have protective footwear so that only the 4 foot will be weight bearing in the offloading. He's okay with it for about 6 months or so. He was all right. And he was very pleased that the limb was okay. What happened for a while subsequently, he was unwell due to various other chest infections that his limb was resting on it. He developed a small ulcer on the weight bearing area of calculum. We went back to the literature. So a lot of articles which say that yes, this resurfacing, if you educate your patient well, that you can salvage it and not do anything. But obviously there's no fitness to it. If you can do a flap, and even the flap that sometimes we don't, the bulky flap that we have is not as good as a God given piece. So a flap would be the next best thing. If you can't flap, if your vessels are bad, if the patient is bad, if there's something that you can do at least to salvage the limb, then you can do this. And then even then, I would probably say we've saved it for you, but try not to walk barefoot at any point in time. Have offloading, if necessary, have an air walker also. So your limb is there, but you want to preserve it. Imagine you've got a below knee amputation. Your weight bearing should take place in the air walker there, not on your foot. Your foot is just for show, and we make sure it is there. You make sure you don't get an ulcer on it. That is the extent to which you need to be careful and warn them. Sometimes you may, a very thin person, if they're okay, it may be okay for a while, but I don't think in the long term it's going to be as good as a plan.
So does it really, is it analogous to overgrafting, which in our old conventional I used to teach us to de-epithelialize and put the second graft?
Yes.
I was thinking in that line. See,
Yeah.
at all we put first
Yes, it is.
2 mm back, 3 weeks later 2 mm back, and then put a graft, maybe it will work.
Yes, and also it is unlike a regular SSG, which is literally plastered onto the tissue underneath. There's no mobility at all. This you have amount of shear, you can move it for trophic ulcers, we use it a lot. You can actually allow it to glide. And Western literature where they've done it on the face, the child grows, and people have become pregnant with it, and it retracts back again. That is the extent to which the elasticity is there.
The expression is compared to dermal matrix, whether to go for the BTM or this thing, because in BTM it's 3 weeks and then integration and then similar, whereas matrix, matridom, they claim direct applications. And matridom, according to their literature, also says in infection absolutely not possible. Whereas in some of the cases, I saw the yellow color thing is polynova actually. So you've used in that. So,
Polycover we used on one occasion. Integra I've used it since 95. Because I was there in the National Burn Unit in Wales, so we used to have it there.
for infection, among these three, which one do you suggest? If there is, I can't get rid of the infection.
Okay, if you can't get rid of the infection, then highly unlikely that any of these are going to work too well. You've got to make sure you're getting it as possible, reasonably good as possible. You can have bad bone, you can have bad tendon, you can have, but it can't be sort of fluffy necrotic tissue. That's a no-no.
One of this question is, we cannot get a culture negative on those.
That will never happen. Yes, agree.
That is what is the point.
Yes, no, that will
That is not
100%.
possible.
Initially, when all the dermatologists started their life, they said no bacteria. Only in a major burn, immediately 80%, 90% burn where no skin was available. We used to do this. Take some skin off, send it to Mount Vernon where the tissue culture lab was available. They will culture keratinocytes and give it to you as a cell suspension, which after 3-4 weeks, once it's vascular, sometimes if it's a deep burn, it even go up to the fascia level. So take off the entire skin, subcutaneous fat, strip it down to fascia under tunicate, apply the matrix, staple it off, put a tight bandage, and only then even release the tunicate. That used to be the extent because you have nothing else. Otherwise, the person is going to die. You will save it. The culture keratinocytes will come. They will still live. But unfortunately, over a matrix, if you don't have autologous epidermis with a sprinkling of dermis, the quality of that reconstruction is lost. It's very good. The minute you touch rub somewhere, your skin will, epidermis will shear off, you'll get a blister forming there. You keep the person alive, but not very happily. So they say like epidermis is life, dermis is the quality of life. So you need a combination of both. So you will have some bacteria. On the whole, our ability to bridge bare bone and tendon seems to be better with Integra. I'm not sure whether it's purely because we have more experience with it compared to Matriderm or not. There are lots of people like JP Hong using multiple layers of Matriderm one over the other. They don't have 3 millimeters in Korea, they have 2 millimeters. So they'll put 2, wait for a while, another week, 10 days, another 2, and then build it up a lot. And certain situations even don't put a graft. We wait for it to epithelialize also. I don't think that's possible because it will allow it to contract to a certain extent. Maybe you do need a graft, but you can definitely build up in multiple layers, it will be used.
Thank you.
Thank you very much. It was those very practical and the pertinent questions when you have a, the supermarket of those substitutes and then which one to choose. So as you rightly said, if infection is your enemy, then you are taking a chance. So any other question, those who are physically present here, because I can see in the chat, there is no more question. So if there, yes, Professor Vijay Kumar, I have another.
Sir, I've always seen in pediatric class, straight class, in all LD cases, the results are good. Yes, in spite of having a lengthy class, in poor presence on the muscle doesn't stretch and they invariably have a dorsal contracture. What is the problem? So I switched on to A and B clamps.
Okay.
But what is the reason, sir? One problem is the LD contracture as they grow, they get even scoliosis. Sometimes that is one big problem. But the second problem is in spite of taking a lengthy flap, most of the toes are going for a dorsal contracture. What is the probability?
This is in spite of their insulin, their massage and such. Okay, because we've seen not in the flap of settings. If the flap is not there, it'll probably be worse.
Yes. Okay.
So maybe that's how you have to console yourself. You can't not do a flap. You'll have to do one or the other. And it's usually not the area of the flap per se, but on the borders.
Yes.
So for example, if we do on the foot, it'll be the big toe and the little toe that are swelling up maximum memory. And you need to tell them that as the child grows till they reach critical maturity, you've got to keep following them up and intervene happening. So it's not just you can do a one-off and deal with it. You're covering the surface, but still deeper. It depends also, I think, on how quickly you're able to do the pre-flap. A lot of starting a set, then there's granulation there, that will contract. Even with the matrix, if you have granulation, you put a matrix on top, the matrix may remain as such, but your granulating bed underneath contract. So ideally, you say you have to scrape off your granulation completely, then you put the matrix, and which is why once the silicone layer is coming off, you have to put in a graft. you miss that area and then that granulation come on top of the matrix. The matrix cannot contract, but the granulation on top of it will contract. So the end result that you want to achieve will not be the same. So it's not the question of wound healing. We are concerned with wound healing most of the time. We are not concerned with the long term. But in the long term, you've got to do all this to be able to make sure that that area of skin that you've reconstructed has no fibrous scar at any layer, either above or below your dermal matrix, and it is able to stretch as much as possible.
This brings to the end of this part of the program. Now we would like to thank our speakers, and for this I request our head of the department, Dr. Friji, to hand over the citation to Dr. Krish, and Dr. Mahapatra can also join. And also a small gift from our side. And we now request Dr. Sathish to give us a chance to say thank you.
Thank you.
And we wish to see you again and again. Doctor, this also a small gift. Okay, sir. We had two senior faculty, Dr. Morgan. So not in the beginning, but in the end, we would like to have a small flower from our side, sir.
Thank you for
Because all the way you came. And to Dr. Vijay Kumar also. Dr. Vijay Kumar, please come. And now we would like to give the certificate of participation. For this, I request our both speakers as well as internal faculty to come and hand over the participation certificates to the physical available here, and rest will get the e-certificate by email. So I call Dr. Vaibhav. Dr. Vaibhav, sir, you please come. Dr. Priji, please join. Because they will be very happy to show the photos of the speakers later on in their career. Dr. Kanav is our MCH first year. Dr. Jacob is our third year exam going MCH student. Dr. Bharat Prakash. Dr. Anand. Of course, we will give to Dr. Vijay Kumar and Dr. Murugan. Because that is the part of our duty to hand over you. Clap for Dr. Vijay. Dr. Padma Lakshmi, I have already handed over when she was just now leaving because she had a call. With this, we have come to the end of this part of the program also. And now I request Dr. Mahapatra to deliver vote of thanks.
Thank you very much, Dr. Sathish Kumar sir and Dr. Krish Kumar sir for agreeing to come here and deliver your lecture. The lecture was excellent. I'm sure all the participants who are online as well as offline would have benefited from the vast experience, the variety of cases we have put, and then series of cases. It was very nice of you to come here. And I'd like to thank all the participants who have come both online and offline. We have circulated this link to almost all the states, as you can see, like East Zone of Plastic Surgery, North Zone, South Zone, everywhere we have circulated. A lot of people have, more people actively interested. And then all these are recorded. it will be circulated later on again for the benefit of all the participants.
YouTube also they can.
YouTube also they can access it. Is perpetually there on YouTube. And I would like to thank our JIPMER administration for this forum for conducting this kind of programs. And with this, I would like to thank Professor Dr. Ravi Chitria, who is the dean for the day today. He is acting dean of JIPMER. He is also part of the program, as well as Professor of Telemedicine for organizing all this telecast online and for all the participants. And I thank the members of the department who have helped us in conducting this program, the telemedicine team. And I would like to thank Chandra from Coloplast who has taken the effort to carry out this event. Thank you very much. With this, I would like to thank all the participants who are online also. We will be meeting again in our next lecture today. Thank you very much.
Thank you, Dr. Patra. I request all of you to rise for the national anthem. You can play from here. No, you can play from here. You can play manually also. You go out and again come back. Go out, again come back. Now play. Oh, it was a silent mode. Yeah. Now you play again. It was in silent mode. Yeah, it was on mute mode, na? Okay. Sir. Jai Hind. Thank you very much.